The Gastrointestinal System. Overview of diseases and approach to diagnosis. In this lecture, we shall review the common disorders of the gastrointestinal system, namely the alimentary system. The liver and the biliary system will be discussed elsewhere. The alimentary system starts with the mouth and ends in the anus. It comprises of the oral cavity, the esophagus, the stomach, small intestine, large intestines, and terminates in the anus. So for simplicity, the disorders will also be discussed according to the different parts of the alimentary tract. Following the mouth, the part that comes is esophagus, and we will start with the disorders of esophagus. But before we start, let us see how the functionality of the alimentary system has been described. The GIT may be thought of comprising of a chopper system, that is the mouth with teeth and tongue, which is transmitted to a blender, acid sterilizer and reservoir represented by the stomach. This leads us to the small intestine, which is the reaction vessel. The reaction vessel receives the detergent in form of bile from the liver and gallbladder, and the enzyme suppliers and pH neutralizers from pancreas and other intestinal glands. The rest of the intestine provides catalytic and absorptive surface. The residue is stored in the large intestine and ultimately emitted by regulated autonomic and voluntary control through the anal sphincter. The first case that we discuss here is the case of a 35-year-old man who visited the outpatient department with difficulty to swallow food. He complained of frequently vomiting out food taken days back. So let us consider the possibilities. With such a very specific problem and streamlined clinical feature, it is actually very difficult to think of multiple possibilities. The key word here is that the person not only has a dysphagia, that is difficulty to swallow, but also he or she is vomiting out food taken days back. That means the food is facing difficulty in transmission. This typically represents an outlet obstruction. The obstruction can be in the esophagus in the form of esophageal carcinoma, at the lower end of the esophagus in the form of Achalasia cardia, or it can also represent gastric outlet obstruction. Achalasia cardia is a very important disorder of motility of the esophagus. As we see in this diagram, in this disorder, there is narrowing of the lower end of the esophagus. Narrowing or stenosis literally translates into achalasia. Achalasia cardia therefore represents narrowing of the cardiac end of the stomach or the lower esophageal end. This causes difficulty in passage of the food, and therefore it accumulates above the narrowed region, causing a fusiform dilation. To understand why such narrowing occurs, let us first review how the normal deglutition pushes food downwards. After the pharyngeal phase of deglutition, as food reaches the esophagus, it progressively moves downward. Food always moves from the oral to the caudal or aboral end. This is the law of intestine or the law of gut. If we see the same mechanism in a real-life video using fluoroscopy, this is how it should look like. This is typically what would happen to you when you are drinking tea. When a bolus of food stretches the wall of the GI tract, particularly the esophagus, it causes release of serotonin. The serotonin stimulates neurons supplying both upstream and downstream. Neurons supplying the oral end of the bolus secretes excitatory neurotransmitters like acetylcholine or substance P. This causes constriction. Neurons going downstream towards the aboral end of the bolus secrete vasoactive intestinal polypeptide and nitric oxide, and this leads to smooth muscle relaxation. Therefore, this results in constriction at the upper end and relaxation in the lower end, and food or bolus will progressively move downward. We can easily understand such a coordinated movement is only possible when there is an integrated and intact enteric nervous system. Achalasia cardia occurs due to loss of the relaxing neurons, and so the constrictive tone at the lower end takes upper hand. Theories of Achalasia cardia vary. The recent consensus is that it is both genetically and environmentally determined. As we can see in this flowchart, there may be some unknown initial insult like viral infection or role of a toxin. And this also depends partly on the HLA subtype and the genetics of the person. The resultant chronic infection and abnormal immune response causes autoimmune antibodies and T cells to be generated. They are directed against the so-called ganglion cells or the neurons of the enteric nervous system. Loss of these neurons, specifically the inhibitory ones, will lead to increased tone of the lower end of the esophagus, causing constriction or achalasia. If we do a barium swallow study, we will see there is a narrowing of the lower end of the esophagus. Evident in these pictures is a very thin thread-like narrowing, above which there is a fusiform dilation. These have often been described as the rat tail deformity. Such narrowing can also happen in esophageal carcinoma, but as cancers develop in an exfoliative manner, the irregularities will be more prominent and it will not cause a smooth fusiform dilation. Clinically, it is also very important to distinguish esophageal cancer causing constriction and Achalasia cardia causing obstruction. In case of cancer, the dysphagia is more to the solids than to the liquids. In case of Achalasia cardia, liquids find it more difficult to pass than solid because liquids cause less stretch than solids. It is very difficult to treat Achalasia cardia. Patients with esophageal achalasia often remain with their symptoms. We can relax the lower end of the esophagus with smooth muscle relaxants. Endoscopic treatment with botulinum toxin has been suggested. There is also some kind of favorable response to nitrates and calcium channel blockers. Finally, when all else fails, a myotomy, which is a surgical procedure, may be performed. A very closely related situation, but etiologically probably different, is diffuse esophageal spasm. Here, not only the lower end of the esophagus, but almost the entire length of the esophagus goes into spasm. On the left panel, we show a corkscrew. It closely simulates the barium swallow image of the esophagus in this patient. So, this image has been described as corkscrew esophagus. The entire oblique musculature of esophagus goes into spasm, often due to no predictable cause. Suddenly, the patient will experience retrosternal pain, and it will be very difficult for food to pass down. Because it also responds to smooth muscle relaxants like nitrates, it's very difficult to differentiate from angina. In both cases, if we do esophageal manometry, we will find that the pressure at the lower end of the esophagus, or in the second case, throughout the esophagus, has been elevated. This brings us to the second case of the day. I am reading the case out for you. A 39-year-old lady visited gastroenterology outpatient department with complaints of frequent heartburn and dyspepsia. The symptoms are aggravated by taking spicy and fried food. There is no hematemesis, melena, or pain in abdomen. When such a patient comes to you, the first thing that you think about is that as there is no hematemesis, that is bleeding from the oral end, melena, that is altered dark blood in stool, or pain in the abdomen, probably we are dealing with a non-malignant, non-ulcerative condition. In this situation, one important differential diagnosis will be acid reflux from stomach back to the esophagus. This is often a very common presenting feature of patients with gastroesophageal reflux. Normally, the lower end of the esophagus remains closed and therefore acid from the stomach cannot reach up. But when the lower esophageal sphincter tone becomes abnormal, this causes acid to travel upwards, causing inflammation. Because unlike stomach, the esophagus does not have a gastric mucosal barrier. What therefore are the factors that regulate the lower esophageal sphincter tone? The physiology of the lower esophageal sphincter tone is complex, and I will not get into that discussion today. You pause and look at this very simplified diagram to see what are the factors that regulate the lower esophageal sphincter tone. But if I simplify this further, it's quite evident that food or acid from the stomach will move up if either the sphincter tone has decreased, the gastroesophageal junction has moved upward, or if the intragastric pressure has increased. So common causes that cause opening up or relaxation of the lower esophageal sphincter are smoking, alcohol, taking aromatic and spicy food. Factors that cause increased intragastric pressure is increased acid secretion, contraction of the stomach, hypergastrinemia, and to some extent, patients who overeat or binge eat. Increased intra-abdominal pressure that can be caused by external factors like tight clothing or due to obesity are also important causes. Lifestyle factors like lying down immediately after taking a meal will cause nullification of the gravity, and so food from the stomach can easily travel upwards. Whatever be the cause, when gastroesophageal reflux occur, as you can see in this simplified flow chart highlighted with yellow color, the initial ulcerative lesion leads to fibrosis and scarring. More there is scar formation, more is the damage to the lower esophageal sphincter. And this causes more acid to go up, and this vicious cycle operates, ultimately either leading to, as you see on the right panel, stricture, pain, obstruction or perforation, or as you see on the left panel, a condition called Barrett's esophagus, which is pre-malignant in nature. We will now discuss Barrett's esophagus in greater detail. We had spoken about this under pre-malignant lesions in the chapter of neoplasia. Barrett's esophagus is a metaplastic condition. Recurrent contact of esophagus to gastric acid causes change in the nature of the lining mucosa. The esophageal epithelium is stratified squamous. As you can see in this diagram, that the pale pink matted finish mucosa of the esophagus is how the stratified squamous epithelium looks like. On the other hand, the dark red, granular, velvety mucosa lying behind, that is the gastric mucosa. In Barrett's esophagus, the lower part of the esophagus loses the squamous epithelium and it gradually becomes replaced by columnar epithelium. Grossly, the lower end of the esophagus would look red and velvety. When we will see it under the microscope, we will see that underneath the pre-existing stratified squamous epithelium, that is represented by this parallel arrangement of cells in the upper part, lie glands lined by tall columnar epithelium that is so characteristic of the gastric mucosa. Presence of glands under the esophageal mucosa is characteristic of Barrett's esophagus. Barrett's esophagus is pre-malignant, indicating that if we do not remove this lesion or treat the lesion early, it will lead to cancer. This kind of metaplasia is columnar metaplasia of the squamous epithelium. And as there is proliferation of glands, it will lead to cancers containing glands and adenocarcinoma. This brings us to the third case. Read the case very carefully. A 50-year-old man, smoker and alcoholic, visited the emergency room with bouts of blood vomiting. What are the possibilities? The age is a factor here. The male gender predisposes to carcinoma. Smoking and alcoholism partly predisposes to gastric cancer as well as to esophageal cancer. And alcoholism itself can also lead to two more important things: cirrhosis of liver causing variceal bleeding, or a very special phenomenon called Mallory Weiss syndrome or Mallory Weiss tear. All these differentials that we discussed now are very important causes of hematemesis, and we will review them one after the other. Coming over first to Mallory Weiss tear. Mallory Weiss syndrome is this phenomenon when a person after intake of alcohol has retching, vomiting, and blood-stained vomitus. It's a very dramatic presentation. Despite being very dramatic, the prognosis of the disease is relatively good. If we see an endoscopic view of the esophagus, there are longitudinal tears in the lower end of the esophagus, which are labeled here as shown in the diagram as Mallory Weiss tear. On the right hand side, you can see it is an endoscopic view showing a longitudinal tear at the lower end of the esophagus. How these tears occur is a matter of controversy. Some people believe that alcohol causes spasm of the lower esophageal sphincter, and as food forces out due to the emetogenic action of alcohol, it tears through the mucosa. Some others believe that alcohol relaxes the lower esophageal sphincter. When a cylindrical organ relaxes, its diameter and circumference increases. As the esophageal mucosa does not have any villi or rugosity, so stretching causes longitudinal tears. Both are plausible explanations, and maybe both are responsible to a certain degree. Mallory Weiss tear does not require any specific treatment. Endoscopic observation, control of bleeding by photocoagulation if it is excessive, or simply a proton pump inhibitor and occasionally sucralfate for healing is sufficient. Clonazepam may be given for anxiety, and the person should be referred to the medicine or psychiatry outpatient department if alcohol de-addiction is necessary. This picture represents the esophageal varices. In cirrhosis of liver, there is obstruction to the portal vein, so the portocaval anastomosis open up. The esophageal and the short gastric vessels become swollen with blood, and they appear as a bag of worm in endoscopic view. Sometimes there are dark red spots on these that indicate impending rupture, and these are also called cherry red spots. Esophageal varix will be discussed in greater detail under cirrhosis of liver. For the time being, we will understand that esophageal varix represents dilation of the esophageal veins. They rupture on the mucosal side and torrential hemorrhage can occur. The condition may be life-threatening. A barium swallow will show irregular filling defect, each defect representing a swollen vein. A portal venography shows dilated portal vein and uphill dilation of portocaval anastomosis. The treatment is difficult. The best treatment probably is a transplantation of the liver. The portal hypertension can be controlled with beta blocker or with terlipressin. Local bleeding from the esophagus can be controlled by coagulation using laser, endoscopic surgery like sclerotherapy, or a very special type of clipping operation known as endoscopic band ligation. This specimen shows a specimen of esophagus that has been cut open longitudinally. You can see at the center there is a gelatinous ulcerated mass. This represents an esophageal cancer or esophageal carcinoma. Carcinoma of esophagus are mostly squamous cell carcinoma. A very few of them are adenocarcinoma. Etiologies of esophageal carcinoma are varied. Common etiologies are smoking, alcohol, and even Achalasia cardia. Achalasia cardia, because of stasis of fluid and food, cause increased exposure of carcinogens to the mucosa of esophagus. This can predispose to esophageal cancer. Apart from that, Achalasia cardia can also cause increased incidence of reflux, increased risk of aspiration pneumonia, and stasis esophagitis. Coming back to the etiologies. We have already learned in hematology that iron deficiency may often be complicated into Plummer-Vinson syndrome. It is a syndrome of glossitis, dysphagia, koilonychia or spoon-shaped nail in the background of iron deficiency anemia. The dysphagia is caused by an esophageal web around the cricoid area. This esophageal web is a pre-malignant lesion and can give rise to squamous cell carcinoma. Dietary nitrosamines are often present in charred protein in food like steak or kebab. These dietary nitrosamines are highly carcinogenic and are implicated in esophageal, gastric, and colorectal carcinoma. And as we have already discussed, Barrett's esophagus is an important etiology of esophageal carcinoma. This is one important etiology that would cause adenocarcinoma rather than squamous cell carcinoma. This is the histological picture of squamous cell carcinoma. Observe carefully. There are islands or nests of dark staining cells with hyperchromatic nuclei. Within this nest or cluster of cells are dark pink colored concentric bands. These concentric bands are also known as keratin pearls. These are caused by deposition of keratin by these differentiated keratinocytes or squamous cells. Presence of epithelial cell nest along with keratin pearl is pathognomonic of squamous cell carcinoma in any part of the body. The remaining 10% of esophageal cancer are adenocarcinoma.